All right, welcome everybody to the Spring University of Toronto Transfusion Medicine Rounds. Thank you so much for joining us. This video conferenced event is streaming to YouTube as a pilot today and will be recorded, archived. Excerpts may be used for educational purposes, so by participating, you indicate your consent to recording, archiving, and use for educational purposes. So please keep yourselves on mute. Keep loading your questions in real time in the chat box and be on watch for the evaluation line item. We need this to keep improving our rounds. We always appreciate your feedback. These rounds are delivered via OrbCon, and we're grateful to our sponsors, so Alexion, CSL Behring, Grifols, Octapharma, Ortho Clinical Diagnostics, Immucor, Takeda, and Instrumentation Laboratory. And I'm delighted that this month, the International Women's Month, we have two outstanding role models and speakers, junior career individuals, experts in transfusion medicine, Dr. Aditi Khandelwal and Amie Kron, who are going to be speaking as our special Ks on stewardship matters in our discipline. So Dr. Khandelwal will be addressing plasma transfusion practices in Ontario, and Amie Kron will be talking about an interesting study on stewarding red cells through our laboratory technologists. And so the way this is going to play out is each speaker will give their talks, and I'll be introducing their bios. We're going to be saving all of our questions to the end of the session. And with your chat box questions, those of course will be prioritized, but you can unmute yourself at the very end when we have space for audio time. So to begin with Dr. Aditi Khandelwal, she completed her undergraduate medical training at McGill University, followed by residencies in internal medicine and adult hematology and a fellowship in transfusion medicine at the University of Toronto. She's also completing a master's in systems leadership and innovation. She works as a medical officer for Canadian Blood Services, and her areas of interest include donor selection and safety, hemovigilance, recipient safety, patient blood management, rare blood procurement, and improved transfusion practices. Amie Kron completed her honors biology degree at McMaster University in 2015 and went on to complete her Master's of Science at the Rehabilitation Sciences Institute at the University of Toronto in 2017. In her academic career, she's been involved in research spanning disciplines from rheumatology to psychiatry and pediatric rehabilitation. With an interest in coordinating multi-center trials, she joined the Quest Research Program in 2019. And she currently works under the dedicated mentorship of Drs. Jeannie Callum and Yulia Lin to improve the safety, utilization, and management of blood products in transfusion practice, the namesake work of Quest. So with that, we'll have our first speaker, Dr. Khandelwal, also a cherished colleague, begin with her talk.
Thank you, Christine. I'm just in the process of sharing my screen. Okay, here we go. Please let me know if at any point there are some lags and I can stop the video and continue the audio. So today I'll be talking to you about appropriateness of plasma use in Ontario. And I'm actually talking to you on behalf of a large team of people who have been the investigators for this project, as well as many more who are not listed here, but are valuable team members, including our MLTs and all of our labs, who work tirelessly to get us the data and ensure that we continue using our products appropriately. And so we have many collaborators, including OrbCon, Quest, as well as McMaster University and McMaster Center for Transfusion Research, University of Ottawa and their research institute, as well as Western University. Directly or indirectly, we received funding from OrbCon, MCTR, Quest, and Canadian Blood Services. So important that I mentioned that the opinions I'll be sharing today are mine, and the conclusions have been reached through the study and not necessarily the opinions of the various organizations that fund this study. Also, I'm very fortunate to live in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. So without further ado, you know this well, being involved in the world of transfusion, the plasma is an extremely precious resource. And inappropriate plasma use, not news. We know this has been going on. It's a universal problem, not just in Ontario. In 2007, we discovered that 45% of plasma use was inappropriate. But we also know this is going on around the world in other provinces in Canada as well. In studies done in Australia, New Zealand, in the ICUs, we know that 26% of plasma transfusions were given to non-bleeding patients with an INR that was within what we would call a normal range. Prior audits have been quite limited because they have been retrospective in nature with chart reviews. That limits the number of transfusions that you can look at. And when we use plasma for transfusion inappropriately, the one place this plasma isn't going is to make purified protein products like IVIG. And currently in Canada, our self-sufficiency rate for provision of IVIG is only about 13.5%. We spend a lot of money in our country to procure IVIG and protein products, about $656 million in the 2018-2019 year. And this accounts for a large part of operating budgets for blood services like Canadian Blood Services. We also know that shortages for protein products are coming, especially because of the pandemic. So it becomes all the more important that we pay attention to where we're using products and how. Plasma is not a benign product. Just like other transfusion products, it is associated with other adverse events. And taco trolley being the leading causes of transfusion-associated mortality are some of the more common adverse events that can be seen with plasma higher than other products. Trolley risk is 7 times higher with plasma compared to red cells, and taco risk is also higher because of the volume that needs to be given to give a proper dose of plasma. Plasma use is associated with harms to specific patient populations where you might actually see plasma used, such as those who are critically ill patients with shock. There's higher risk of ventilator-associated pneumonia, as well in patients undergoing surgery, non-cardiovascular surgery in particular, and have elevated INR, then subsequently receive plasma to correct that INR. We know that in these patients, the risk of bleeding is actually higher, not lower. So plasma is not without its dangers. So where do we actually use plasma? What are the indications? I will mention these indications, but just say that the quality of evidence that supports any of these indications most of the time is actually low to moderate at best. So indications for plasma use that are qualified as acceptable based on consensus guidelines and some research are patients who are having a significant bleed, a moderate to severe bleed, or in order to prevent periprocedural bleeding in patients who have had acquired factor deficiency, which some guidelines will choose to identify with an elevated INR value. Warfarin reversal only if a PCC is not available or contraindicated, such as in patients with HIT. And factor replacement if a factor concentrate is unavailable. Here I put an asterisk because in this situation, there may be a role for a product called solvent detergent plasma. And apheresis for patients with specific indications such as TTP or those who are bleeding. Again, there's an asterisk there because there may be a role for another product called solvent detergent plasma. Importantly, plasma is not indicated if a patient is not bleeding and does not have a planned procedure, if warfarin reversal is desired and PCCs are accessible or not contraindicated, if there's only a mild bleed, and if factor replacement is better done with factor concentrates, which are a safer product. The dose for plasma was actually decided based on laboratory testing showing some increase in factor levels. Presumably a factor level over 30% will allow adequate hemostasis, and that's sort of how this dose was determined, which is now the standardized dose of 15 mils per kilogram, which translates to about 4 units in a 70 kilogram individual. We know from real world studies that about only 1 in 5 patients with low factor levels will end up increasing their factor levels to over 30% after a standard dose of plasma. Median dose in this study that was done in an ICU was actually 12 mils per kilogram. And the strongest effect for reversal of INR, if you're treating a laboratory value, is seen when the INR is greater than 2. I'll only caution here saying there really hasn't been good studies linking clinical outcome of bleeding with purely just an elevated INR. So you always have to look at the patient, make a clinical decision rather than a decision based on numbers alone. So lastly, to put it out there again, decreasing bleeding risk with prophylactic plasma when used for elevated INR hasn't actually been established very clearly with clinical outcomes, but it is used widely, and we know that. So what did we want to do? We wanted to see where we're at now in Ontario. We had done this chart review based retrospective review, which was extremely tedious back in 2007 by many of the people who are on this call today. And we wanted to see, have things changed? So we wanted to determine the appropriate length of plasma, and we chose 5 academic centers across Ontario to do so. Another reason to do studies like this is to identify targets for future improvement, quality improvement projects. And that was also one of the objectives. We wanted to include inpatients who were admitted in 1 calendar year, January 1st to December 31st, 2017. So it is going back just a couple of years from now. And they were adult patients, 18 years or older, who received at least 1 plasma unit or more. We excluded patients who were outpatients, pediatric patients, oh, sorry, I have outpatients there twice, or who were receiving plasma exchange for indications such as TTP. We had to come up with an electronic definition of what is appropriate and what is inappropriate plasma use. And we divided up plasma use into plasma indication or plasma dose. You will notice here that under the category of indication, we have 3 different indications that would be considered inappropriate if these criteria were met. If the INR was less than 1.5 before the transfusion of plasma within the 24-hour period before, with no to moderate bleeding, or the INR is elevated within the 24 hours before transfusion, but there is no invasive procedure planned, or there is no INR pre and post plasma transfusion, and no INR within 12 hours after giving the transfusion. The dose that was decided as inappropriate would be less than equal to 2 units, where 1 unit is a 250 ml equivalent of plasma. I want to point out that these definitions are intentionally liberal, so we mitigate overclassification of the events as inappropriate. Most guidelines suggest that INR less than 1.8 be used. Again, we use 1 calendar day rather than 6 hours, the time frame where you would really want to see the effect of plasma or make that decision given the half-life of factors within the plasma product. In the last one, we used no INR within 12 hours rather than 6 hours. Okay. So the definition of bleeding was also developed for this study. Again, an electronic definition. No to mild bleeding was bleeding that didn't fit the moderate or severe categories. Moderate bleeding was when at least 1 unit of red cell was issued within the 24 hours of issue of plasma unit, and or there was a drop of 20 grams per liter or greater in hemoglobin within the 24 hours of plasma use. Severe bleeding was when greater than equal to 2 units of red cells were given within 24 hours of plasma use. The data collection was actually performed using multiple electronic databases. Each hospital's database and the administrative database called CIHI DAD, which is the Canadian Research Institute Discharge Administrative Database, was used. We linked information between the various laboratory information systems, so laboratory information system for the hospital, the blood bank itself, the administrative database, and the hospital's own information systems to get data on who got transfused, what timing, when did they have the procedures, what were their characteristics in terms of age, sex that was reported on file, what were the admission diagnoses, mortality or not, length of stay, types and timing of procedures, etc. And then we also were able to link the timing when the laboratory values were reported with the timing of transfusion. So suddenly it gives us a lot of information that can be extracted and analyzed when we use a database format rather than a manual chart review, which would take a lot longer to perform. The data analysis itself was performed by our colleagues at MCTR at McMaster, and there was an a priori statistical plan before we extracted the data and analyzed it. We also validated the data mapping process prior to the analysis itself that was performed. So this is what you've been waiting for to see. So we had greater than 175,000 hospital admissions that occurred across these 5 large institutions in Ontario. And only about 2,630 of them had the inclusion criteria of an adult patient who got transfused with plasma and did not have TTP or other exclusion criteria. Amongst the 2,630 admissions, there were 2,591 unique patients. And just to give you a sense, 84% of these admissions also involved red cell transfusions, as well as over half of them received platelets, and about 20% of them got cryoprecipitate. Amongst these admissions, over 11,000 plasma units were transfused. The mean age of the patients who were included were 61.6 years, plus minus 16. Majority of them, 63%, were male, and ICU admission occurred in majority of patients who were included in this study. Severe bleeding was seen in over 70% of the admissions. And the top reason for admission that we were able to get from CIHI DAD was cardiovascular disease, which was present in 41.1% of the patients. The second most common reason for admission was trauma. The third was actually gastrointestinal diseases, which would have included liver disease, for instance. So when we looked at inappropriate dose or indication, we identified that 77% of plasma transfusion events were actually inappropriate. So this is data by hospital in a graph format. Along the bottom are the 5 sites. Along the y-axis, it gives you a percentage of transfusion that met the criteria for inappropriate. And there was quite a bit of variability in the dosing or indication across the board. I have 4 colors there. So we'll look at the blue bars first. And this is a combination of either inappropriate dose or indication. So you can see this varies from about 70% all the way up to almost 84%. Inappropriate dose was the more common reason for why a transfusion of plasma event was classified as being inappropriate. And this also varied from about 52% to almost 80%. There were instances where we saw both an inappropriate dose and an inappropriate indication. And this is shown to you in the yellow bars, and this varied from about 16% to 34%. So I'll divide this up and show it to you again in the next few slides. So this is the plasma dose data, 71% of the events on average. So I showed you by site, but on average, 71% were underdosing. On the pie chart there, 1 unit of plasma was given in about 25% of the events, and 2 units were given in 45%. So both of these combined would have been adjudicated as inappropriate. The mean dose of plasma given across sites during these events was 2.5. And this is actually higher than what we had seen in Ontario in 2007 when we did the retrospective chart review and found that inappropriate dose was given in about 42.4%. So this is significantly higher than that. In terms of indications, inappropriate indications were seen in almost a third of the events, about 35% almost. It ranged from hospital to hospital, like I showed you earlier, from 25 to 40%. 62% of these events occurred in patients who had an INR less than 1.5, who had no or mild bleeding and no procedure within 1 calendar day. So this is clearly a target that we can meet to see if in the future we can improve that. Like I said earlier, we used a very liberal INR threshold of 1.5 rather than 1.8 to mitigate over-adjudication to inappropriate indication. But I wanted to show you the distribution of pre-transfusion INR where it was available. And on the pie graph that I have on the right side of the screen, you'll see in gray the fraction of this pie where INR was equal to or greater than 1.8. And the rest of the pie graph in orange and blue shows you where the INR was less than 1.5. So as you can see, majority were less than 1.5. So again, there was site-to-site variability in INR results. So there's clearly certain cultures at different sites have different cultures, and that becomes important when we're designing interventions in the future. Right. Although we couldn't statistically perform an analysis to compare the appropriate versus inappropriate use groups, what I wanted to show you in this comparison was show you that in the patients where we did have the info about appropriate and inappropriate use, they were fairly well matched for age. The differences that I noticed here were that a larger proportion of patients who had inappropriate plasma use adjudication with the electronic definitions were in the ICU. So 54.9% were in the ICU compared to 44.42 in the ICU with appropriate. So that also helps us determine what kind of targets for our interventions we can potentially think about. And then in the bleeding status, this is selected here that more of the appropriate have severe bleeding, right? Because that's one of our definition points. But it is interesting to see that amongst those who had inappropriate plasma use, there's quite a few who were still having severe bleeding. So that potentially shows you that it was a dose issue where patients are having severe bleeding, but they're probably maybe not receiving the dose that should be prescribed. All right, the mortality is quite significant in these groups. So clearly these are quite sick patients, with a third of them having in hospital mortality. And then in terms of the diagnoses, cardiovascular system diagnoses were the most common. These are probably enriched by CV surgery patients as well, then followed by trauma and, as I'd mentioned before, gastrointestinal diseases. So what were the limitations from this study? Well, we are relying on accuracy of coding when we're thinking about databases and the information that's actually in there. CHI-DID is quite a reliable and validated database. So this is a good database for us to use for this sort of a project. There may have been some invasive procedures that could have been missed despite our best efforts to get the right codes in there. And the definition of bleeding may actually not capture certain types of bleeds, such as bleeds in critical locations, like intracranial hemorrhage. The other limitation is, although I can extract the information about timing of laboratory data reporting, such as INR results or hemoglobin from the laboratory information system, the clinician who is ordering the plasma may or may not be aware of when these results are released, as they may be seeing, there may be a lag between the release of these results and their ability to be able to review the results. So it's always hard to know whether they were aware of the INR values or not at the time that the transfusions were ordered and given. The strengths of these studies is the intentional use of liberal definition still showed us that there is quite a bit of inappropriate plasma use. So this problem has not gone away. And we were able to see this by analyzing a very large number of consecutive events, which we've never done in Ontario before for this purpose. The data extraction was performed in a consistent manner across all of the sites. And we did have quite a bit of data about the timing as well as the diagnoses, which helped really get good information out of this extraction and analysis. We were initially worried that potentially trauma may pull the data a certain way, given 1-to-1 RBC to plasma ratios are used in trauma transfusions, but trauma was recorded as diagnosis in less than 20% of the cases. We don't think it was a large contributor to what we adjudicated as inappropriate use. So in conclusion, our electronic audit of over 11,000 plasma transfusions at 5 academic centers showed us that even now, we have greater than 75% of plasma transfusions that were potentially inappropriate, and a third of these were unnecessary. 70% of these patients were underdosed. A lot of these happened in the ICU, so we need to think about where and how we will target our future quality improvement projects. So that's all I have for you today. We'll take the questions at the very end. So I'm going to stop the presentation now.
Thank you so much, Aditi. That was super stimulating, and you'll see that there's some discussion already in the chat box that you can enjoy reading and even responding to in parallel. We will open up the floor now at the halfway mark to Amie Kron. Amie, get you off muted.
Yep, sorry, I was just trying to figure out my screen sharing. So thanks, Christine, for the introduction. So I'll be presenting on the START study, screening biotechnologists and auditing to reduce transfusion. I'm a clinical research coordinator at Sunnybrook, and just wanted to recognize that this was a collaborative effort. As you can see at the bottom, we had several team members, and funding was from our 2016 Canadian Blood Services Intramural Research Grant, as well as the Sunnybrook Foundation for the Transfusion Medicine Fund. So I do not have any conflicts of interest to declare. So in terms of the outline for this presentation, I'll be going over the background rationale for the study, go over our research objectives and our hypothesis, quickly kind of go over the study design and then our outcome measures, give you an overview of our results, and then we'll have a bit of a discussion and I'll go over some of our limitations. So to start, we know that transfusion of red cells is an overused therapeutic intervention, with about 1 in 4 to 5 red cells being transfused in patients being considered inappropriate. We also know that red cells are costly and they are in limited supply. And as well, red cell transfusions are associated with adverse reactions such as TACO and TRALI. It has been shown in the literature that quality improvement initiatives aimed at promoting the use of red cells have the potential to improve patient and donor outcomes. So the objective of our START study was to determine the impact of a multifaceted intervention to improve the appropriate use of red cells across 15 hospitals in Canada with a baseline appropriateness rating of under 90%. These hospitals were across 3 provinces, mostly in Ontario and also including Saskatchewan and Alberta. We hypothesized that implementing our intervention would reduce the rate of unnecessary transfusions to less than 1 in 10. And the reason that we were doing this study was we want to provide a framework for the design of future transfusion quality improvement initiatives to promote minimizing patient exposure to the risks of red cell transfusion, as well as improve the appropriate red cell utilization and help ensure adequate supply of red cells. So our secondary objectives were multifold. The first being we wanted to determine what was the baseline appropriateness rate for red cell transfusions at 15 hospitals across Canada. Also determine what were the most common clinical features of the patients and the specialties of ordering physicians for which the red cells were being inappropriately ordered. We also want to test the effectiveness of our intervention to improve the appropriate use of red cell transfusions at hospitals who had a baseline unnecessary transfusion rate of greater than or equal to 10%. And lastly, determine what the costs and savings were in terms of the red cell transfusions that were avoided. So moving to our study design, we started with our site assessment and recruitment phase, which included 23 hospitals. We started by identifying hospitals who transfuse greater or equal to 2,000 red cells per year and greater or equal to 4 red cells transfused per 100 acute inpatient days monthly. We had these sites complete an eligibility assessment survey to help identify what are the barriers and facilitators to administrating this intervention, as well as to determine what the willingness was of the MLTs to actually perform the data collection. After this recruitment phase, we had 7 hospitals who did not participate due to lack of staff and resources. And that brings us to our pre-intervention phase, which lasted 5 months and included 15 hospitals. So to provide more detail on our pre-intervention phase, which was our baseline audit, it lasted 5 months and included, as I mentioned, 15 hospitals. These are medium to large size mostly community hospitals and across 3 Canadian provinces. We had the MLTs collect data on the total of 50 red cell units transfused to inpatients from all locations, determine what was the baseline appropriateness for these hospitals. So that was 10 red cell transfusions audited per site per month for the duration of 5 months. We did exclude outpatients, those with sickle cell anemia, thalassemia, as well as those that were less than 18 years of age, and that's due to different thresholds and indications for transfusion. And we also had the transfusion medicine specialists independently and duly adjudicate these red cell units for compliance of guidelines based on preset adjudication criteria, which I'll get to in a moment. The MLTs also collected pre-transfusion hemoglobin of 50 consecutive red cell transfusions per month. And separately, we did also collect the total transfusions per month for each site. For our adjudication criteria, I won't go into too much detail for this, but for asymptomatic non-bleeding patients, our restrictive threshold was a pre-transfusion hemoglobin of greater than 70 for patients with no known cardiac disease and greater than 80 for patients with known cardiac disease. For bleeding patients, we had more lenient criteria. In terms of the adjudication, they could go either off of the pre or post-transfusion hemoglobin. So after our pre-intervention, there were 2 sites out of the 15 that had an appropriateness of greater than 90%. So that left us with 13 hospitals that moved on to the intervention phase. So our intervention phase lasted 3 months and consisted of several things such as adopting standardized red cell guidelines. We also had education via short PowerPoint talks and screensavers. The PowerPoint talks were either presented at rounds or also pre-recorded. These are some examples of the screensavers and flyers that could be posted around the site. So for example, why give 2 when 1 will do, and more is not always better. We also had in our last month a pilot of MLT screening of suspected non-compliant orders for approval before issue. And this happened 9 till 5, Monday to Friday in the last month before we moved on to the 24/7 screening in the post-intervention phase. And there was also monthly auditing of appropriateness with feedback from the clinical team. Important to note here that for the START study, we did not require a transfusion medicine specialist to be on site. Instead, we had a local physician champion that was appointed at each site, which was done during the recruitment phase, and they would help to oversee the implementation of the study as well as serve as the main contact for physicians who had their transfusion orders flagged. To give more detail on our audit procedure, we had the MLTs perform a medical chart review for patient demographics and transfusion details using the OrbCon audit tool. And then audits were faxed to the central coordinating site and then entered into REDCap. This allowed the transfusion medicine specialist to duly and independently adjudicate the units, and then discrepancies were resolved by consensus. To avoid bias, only 2 units were audited per patient. And in the case of transfusion orders for more than 2 units, we had a computerized system that randomly selected which unit we asked the transfusion medicine specialist to review. For the prospective auditing, in terms of what we had included in these pre-recorded training modules for the MLTs, we really emphasized their role to prospectively audit the transfusion orders, that it's within their scope of practice. And as I mentioned, we had the pilot 9 to 5 weekdays in the last month of the intervention phase before we started our 24/7 screening. The MLTs through this PowerPoint were also able to review common scenarios, and we also discussed the need for physician champion backup and support. So our post-intervention phase was basically done in 2 parts. It did last a total of 10 months and was identical to the baseline audit. So I won't go over all of this again. We collected the same information as the baseline audit. Just to stress that we didn't screen all inpatient orders. We screened all inpatient orders, but excluded bleeding and OR patients. And that's because we didn't want to interfere with urgent transfusion order requests. And the first half of the post-intervention phase, we really wanted to focus on the effectiveness of the intervention. And the second half, we wanted to focus on the sustainability of the intervention. For outcome measures, our primary outcome measures were to look at what is the proportion of red cells adjudicated as appropriate out of the 50 units audited during the pre-intervention phase and the 100 units audited in the post-intervention phase. We also want to look at the proportion of single unit transfusions and the total number of monthly red cell transfusions, as well as the monthly red cells transfused per 100 acute inpatient days to look at changes in red cell utilization. We did compare this point with controls for each participating site. We had them matched to 2 control hospitals by bed size. We didn't gather any transfusion details or audit anything from the control hospitals, but it was just used to look at changes in the monthly red cells transfused per 100 acute inpatient days from pre to post intervention. Our process measure was the median pre-transfusion hemoglobin that the MLTs provided us with for the 50 units audited per month. And as a balancing measure, we know that there are some criticisms of these interventions with risks to undertransfusion. So we looked at undertransfusion events, ICU admissions, infection rates, length of stay, and inpatient mortality per 100 acute inpatient days compared with controls. So moving to the results, here is a summary of the demographics and the transfusion details for the audited patients. There were no differences in the baseline characteristics for the pre and post intervention periods. We had 1,950 patients audited and about 3,000 total red cell units transfused. I won't go into detail, but as you can see here for the demographics, they're pretty classical diagnoses of gastrointestinal disease, as well as cardiac comorbidities. For the transfusion details, you can see that most transfusions were administered in the inpatient ward for patients that had an indication of bleeding or low hemoglobin without symptoms being the most common indication. And the most common MRP specialty was internal medicine physicians as well as emergency docs. When looking at the single versus multi-unit transfusions, we saw that the proportion of single-unit red cell transfusions did significantly increase from pre to post-intervention. And the majority of multi-unit transfusions were prescribed to bleeding patients, and 25% to either those with symptomatic anemia or low hemoglobin without symptoms, and this did not change from the pre to post-intervention periods. For our process measure, we did see overall a decrease in the median pre-transfusion hemoglobin from pre to post-intervention. On the x-axis, you can see the participating sites, with the very right being all sites combined, and on the y-axis, the median pre-transfusion hemoglobin. And we've separated it by the gray bar being pre-intervention and the blue and red bar being post-intervention 1 and post-intervention 2, respectively, for the first and second 5 months. You can see that there is a decrease for each site, but we did not see significance for each site, which I'll get to a little bit later. Also, for our pre-transfusion and post-transfusion hemoglobin, you can see that as we went from pre-intervention to post-intervention, the proportions of transfusion in each category actually increased as we decrease for the pre and post-transfusion hemoglobin levels. In terms of appropriateness, for the 15 months total, 81.2% of red cells were adjudicated as appropriate, and the proportions did increase significantly from pre to post-intervention. Emergency physicians did fall into the lowest range of appropriateness, and most inappropriate transfusions did occur in the inpatient ward. Looking at the total number of red cells transfused, so this was separate from the audits. On the x-axis, we have the month for the intervention. On the very right, just summarizing it to pre and post-intervention, and on the x-axis, the total number of red cell units. And we did have a significant decrease in the number of red cells transfused, an average decrease of about 500 units per month. Also, estimating the total per year, it's about 5,500 red cells per the 12 months for the 13 hospitals. So I wanted to stress that not all our outcomes were statistically significant. This figure here, the very left column, you can see all the sites, and on the top, we have our primary outcomes, the green being significant changes and the red being non-significant changes. And the reason being that we weren't able to assess significance at all sites is because our study was not powered to do this due to site and cost limitations. We had the 50 audit number that we used for the first 5 months, and then the post-intervention 1 and post-intervention 2 allowed us to preclude significance overall, but not at individual sites. We also looked at what clinical inpatient scenarios had the lowest percentage of appropriate transfusions, and this was asymptomatic non-bleeding patients with the pre-transfusion hemoglobin greater than 70 with no known cardiac disease. So to look at our under-transfusion events, we had all the sites identify in patients who had a hemoglobin less than 60, a pre-transfusion hemoglobin less than 60 over the study period, and also did not receive a transfusion within 48 hours after that reading. And we did have 194 total events, but only 4 events were not explained by either a laboratory error, like an erroneous laboratory value, or a clear medical religious reason. The 3 most common reasons for not transfusing the red cells was the most common being patient was deemed hemodynamically stable, it was an erroneous laboratory value, or the patient refused transfusion. So this graph here shows that we did see a decrease in monthly red cells per 100 acute inpatient days. However, this did not change hospital deaths with respect to the control on participating sites. Interesting to see that despite us having a decrease of about 5,000 units of red cells, that we did not see any significant changes in inpatient hospital mortality. We did have a relative decrease for the participating sites of 13% from pre to post-intervention implementation. Similarly, there was no impact from the intervention on ICU admission rates, total acute inpatient days, and inpatient mortality per 100 acute inpatient days with regard to significant changes following intervention. So moving to the discussion, so just to summarize the results here, we did see that the intervention increased the appropriateness, reduced pre and post-transfusion hemoglobin, increased single unit transfusions, decreased total number of units transfused as well. We had an overall reduction in red cells of about 5,000 units, which we were able to calculate an activity-based cost savings of about 3.1 million over the 10 months of the post-intervention phase. We did not reach appropriateness of greater than 90% for the intervention at all sites. That was for 8 of them, and 3 were actually less than 80%. Evidently, additional interventions or additional time are needed to achieve this greater than 90%. Some MDs are late adopters, and we know that there are different institutional cultures with regard to adopting a restrictive transfusion strategy as well. So I want to bring up the quality improvement plan brought forward in 2016 from Transfusion Ontario. They called for a 20% improvement or 80% appropriateness by 5 years on single unit transfusions and transfusions with a pre-transfusion hemoglobin less than 80. The great news is that all except 2 sites that participated in our study met this 5-year target, and this is pretty much owed to staff education and prospective MLT screening. The absolute and relative decreases of the monthly red cells per 100 acute inpatient days transfused were about half those found from a previous pilot study. And that can be owed to the fact that the START study, we had local champions versus transfusion medicine specialists. So this pilot study was an audit done in 3 hospitals that had a transfusion medicine specialist on site. So I wanted to bring up the Using Blood Wisely campaign, which is helping to disseminate the same principles as the START study. Currently, there are 159 participating hospitals, and by meeting the benchmarks for 4 months, which are at least 65% of the hospital's transfusions are single unit, and at least 80% of inpatient red cell transfusions have a pre-transfusion hemoglobin of less than 80, then they can achieve a designation of a Using Blood Wisely hospital. And it's great to see that since the last month that there have been 3 new hospitals that have received this designation. So just to end with some limitations of our study, so we weren't able to screen all transfusions, such as bleeding in OR patients. As I had gone through previously, it was difficult for us to assess significance at all sites because we weren't powered to do so. We also had very rigid adjudication criteria. So for example, 70 would be considered appropriate, but 71 would be considered inappropriate. The hospitals that did participate had willing local champions. So we wonder whether we can generalize this to less willing institutions. Also, most were community hospitals. 2 out of 13 that ended up participating were academic. So again, speaking to the generalizability of this to academic hospitals, not sure if it would have the same impact. Also, we weren't able to collect data on the proportion of MDs and nurses that actually watched the educational materials, so it's difficult to measure what the uptake of the QI initiative was. Also, the intervention involved the co-Is Dr. Jeannie Callum and Dr. Allison Collins actually visiting the sites and training at Grand Rounds, whether this would be possible for sites implementing this intervention moving forward. Not sure if that would be feasible. Also, there was unplanned one-on-one coaching once the intervention had been implemented. So just some key takeaways. So as you can see, the START study led to a decrease in the total number of transfusions, an increase in appropriateness. Really, this provides us with a robust framework for other institutions to improve their appropriate use of red cells. A reduction in inappropriate red cells, we know, can translate to a direct impact to the safety of transfusion recipients as well as donors. And by providing appropriate transfusions, we can help preserve red cell supply, as well as reduce the need for donors and help Canadian Blood Services forecast their blood utilization. So thank you so much for your time. And I guess we'll take questions at this time.
All right, thank you so much, Amy. I want to commend the entire START study franchise. It was clearly research money well spent in terms of the enormous returns in savings. And I wish that, this banding together can-do attitude of a lot of work that went into many people at many hospitals could apply to the COVID pandemic. I think if we had that positive energy and compliance, that the world would be a much better place. So I think that you transfusion medicine folks are just amazing examples to everyone. Thank you. So we'll open up for questions. There were some chats going on alongside Dr. Khandelwal's talk just on the non-feasibility of reappropriating unused long frozen plasmas just for fractionation in the spirit of conservation if this message gets taken up really well by users. And then questions on the phenomenon of why undertransfusion is increasingly prevalent. So some interesting speculations there, and very appreciative of the feedback from Tanya Petrosco and Rob Romans, Ziad Zoll. So I won't reread everything there. So we have a question from Nikki Paludi at WRH. I would say very few doctors and RNs viewed any of the education provided. It was the MLTs in the department doing the education, so more a comment. I guess I have a question for you. What do you think was the hardest aspect of this? And what's the easiest, or what would you recommend in implementation? I think using blood wisely was probably informed very much in what to do based on the findings of the START study. But do you have advice for people in this pre-implementation game?
So with respect to the intervention, I guess I'll invite my co-stars Yulia and Jeannie to speak to the intervention, as I was not particularly involved in that piece.
Christine, you're asking in terms of, in this pre-implementation, any words of wisdom of?
Yeah, what was hardest? What's best to avoid? What really works well? What's easiest? If you had to pick your favorites and least favorites for advice.
I think the education, like the background education, is really, really important, getting buy-in for the guidelines from the users. So everybody kind of believes in adopting this and getting really wide stakeholder consultation so you understand what your obstacles are. And I think screening, as long as we don't tell anyone else this, screen from 8 in the morning till 10 o'clock at night and sleep, through the night. It's very difficult to screen in the middle of the night, and those aren't really productive conversations, but do as much screening as you can during those daytime hours to identify the doctors that really are late adopters. They're really nervous. Like some doctors still want hemoglobins of 100. Use your daytime hours to find those people and follow up with them. And I think the MLTs are this amazing power engine across this whole province that they're amazing. They're flagging iron deficient patients that should be getting IV iron instead of blood. They're flagging the wrong dose. They're flagging the wrong timing, wrong patient. They're amazing, and we need to harvest their energy to improve transfusion practice. That's how we're going to fix this problem. And, we're in a bit of a mess in terms of, basically everybody getting plasmas getting a placebo dose in the province.
Thank you for those comments. So some more extended comments here in the chat box. You really need MAC buy-in, and the MLTs have to know that screening is in their scope and that they're allowed to ask questions. So, some of this is empowerment. So I'm curious so this is a question to both Aditi, Amie, Jeannie. How do you think the pandemic and our digital interfacing with each other in education is going to connect with all of this? Do you think that we're going to be more or less powerful? Are people more tuned in, more tuned out? Is this an opportunity for easier attendance? I mean, how do you foresee our mode of interacting with each other in pandemic times as an interaction with these missions of conservation?
Okay, I'll take a.
Are you
I'll take a try
optimistic
at-
or pessimistic?
I am an optimist, so I have to say that I think in some ways during the pandemic, it is acceptable to reach out to people electronically or make phone calls. In my training, I did a lot of just showing up in the ICU when there's, a massive hemorrhage going on and talking to the physicians through that. And that was very valuable. But I found that during the pandemic, you can reach out even further and people are okay with you reaching out electronically or from a distance, and still willing to engage depending on what's going on. So, and in transfusion medicine, we're often at a distance. We're often a little bit farther away. People don't often remember what we look like because we haven't seen them in a while, unless you're Jeannie and you just go there, or Yulia, you're there in person. But a lot of the times, a lot of our interactions were already over the phone or via email or discussions that were electronically happening. I think people are just more open to those right now. And I feel like as a community, we have worked through a couple of very big projects as a transfusion community during this last year during the pandemic, and the communities come together to do a lot of good stuff. And I think that's only fostered this sense of being really involved in doing something new and doing something differently to make something really valuable happen. So I personally think that there is a lot of good that has come out of the uptake of a technology during this time. And I think we can use it further for improvement of transfusion practice. And being at a distance is our new reality anyway. So I think we will have to embrace it even more going forward.
I love that hopeful note. Yulia.
No, I just wanted to make a comment that, for sure the START study was informing using blood wisely. And at the start of the pandemic, actually, the pandemic helped to spur on hospitals because there was such a concern about blood shortages that didn't pan out. But in fact, it really spurred on a few of the provinces, Saskatchewan and Manitoba, to just push through prospective screening and really make those changes like at, far rapid, far faster pace than would have been if we were just doing it without the pandemic and kind of just doing it by training and trying to, goodwill. There was a lot of push for that. So there were really good things about the pandemic for blood.
Also on the transfusion camp side, like the enrollment doubled post-pandemic when people didn't have to come in person. So it's kind of shown us, what people prefer. And it's a lot easier to give talks post-pandemic if you just have to dial in for an hour rather than having to fly to a new location to give that talk. So, it does open up some opportunities we didn't think about before.
Yeah, in essence, maybe we're even more available than we ever were before. And maybe it doesn't matter that there are only a few hospitals that have on-site transfusion physicians. We're closer by video calls, and now we've got faces to voices and not just voices over the phone. So maybe that humanizes or cools down a fractious interaction otherwise. Okay, so I think we're 1 minute to the hour. I want to re-invite everybody back for next month's rounds. It's going to be on April 22nd, cold immune hemolytic anemia, clinical aspects, advances in treatment by Dr. Eileen Weitz. So do attend, and please click on your evaluation link. And before we sign out, happy Passover, Palm Sunday, Nowruz, all of your festivities. Be well, be safe, be safer than ever as we face maybe a third wave of this pandemic. So I'm wishing everyone the best in health and happiness. And thank you so much again for tuning in. This was a super important topic and multi-component. So we're really grateful to the incredible work that these teams have done and to the speakers who conveyed it to us. So thank you for inspiring us all to be better at our craft.